We are at the top of the hour, but if you can write in the chat where you're tuning in from and how long you've been in private practice, that'd be great. And Scott, if you want to start, you can share where you're tuning in from and how long you've been in private practice.
Ocean City, Maryland,
Nice.
28 years.
Harrisburg, Pennsylvania, and we are 23 years in now. Got it. Jim Taylor, Metro Atlanta, Georgia, 2 years. John, I'm not even going to try to pronounce your last name, John. Johnson City, New York, 25 years. Trevin, 27 years, Riverside, California. Kimberly, Chicago, it looks like since 2014. PT since 1999. Awesome. In our time together here today, we're going to walk through 3 ways to improve your payer mix with marketing. And Scott, I mean, just to open up here, very much appreciate you doing this. We're going to get into talking about the macroeconomics of what's happening in private practice and everything that you're representing with the UPTA and also and how you're helping private practice owners. But I do want to open up with thank you for doing this.
Thank you. Appreciate it.
There's a poll coming up on your screen right now. And what are you doing today to improve your payer mix? I know Scott shared that your 60% of your payer mix is Medicare. Just got a little bit of a haircut here. We're in that same ballpark, 50 to 60%, depending on our clinic location. Varies from clinic to clinic, but we're having to work harder and harder because of that declining reimbursements. If you can answer that, what are you doing today to improve your payer mix? Dropping a low payer or thinking about it, changing your scheduling and treatment times, maybe going from 60 minutes to 40 minutes or 30 minutes, something like that. Attracting more of your best payer, renegotiating rates, adding a cash pay or add-on service. We'll keep that up for another 5 seconds here. 4, 3, 2, 1. Great. And I'll read you the results here in a second. And just out of curiosity, Scott, what are you doing for your practice right now?
We just dropped United Healthcare, which is our lower payer. That's basically the thing we've done this year is get rid of United Healthcare.
Nice. 38% we're dropping a low payer, 50% we're attracting more of our best payer, and then 13% adding a cash-based service. And then you can just put this in the chat. What's the best thing you've done to improve your payer mix? Scott, we have your answer. And in all fairness, in the prep conversation that you and I had around this, you also said that you pivoted to attracting vestibular balance and dizziness patients as well,
Right.
which improved your lifetime patient value and was a better patient for you to see long-term for your practice and something for you to build around. Cool. For everybody else on the call here, what's the best thing you've done to improve your payer mix? You can type that in the chat. And then very quick housekeeping here. Be present, eliminate distractions. I just turned my phone off. I think we're good there. Grab something to write with and write on. And then Scott doesn't even know this. We have an exclusive announcement here at the end, which will be great. It's a really good surprise. You're in the right place if you're a practice owner, you want to help more people, you want to increase your revenue per visit, you want to increase your margin of safety for your practice, you want to stand out from your competition, and you want to attract better paying patients. And for our agenda here today, first thing that we're going to go through is the UPTA. Scott's going to talk about what it is, the purpose, the mission, the vision, and also what he and the association are committed to help move private practice forward. And we're going to talk about the 4 pitfalls for the private practice owner. We're going to go through the 3 marketing strategies that are probably the 3 easiest to execute for promoting your services and improving your payer mix. I'm going to share a system to improve profitability, and we'll also have time here for Q&A at the end. Just to catch up here, what are you doing to improve your payer mix? John shared attract more balanced vestibular patients who happen to be mostly Medicare payers. Kimberly says drop all low payers. Love it. Jim says bring in more balance in vestibular and looking forward to dropping UHC. Scott, if you want to go through here, be great to go through the mission and vision for the UPTA.
Thanks, Chad. We started the UPTA last summer. We got up and running in October, as everybody knows. Our goal is to advocate for, fair compensation, reduced burdens, and sustainable careers for physical therapists and assistants across all settings. Our goal is really to be more of a grassroots advocacy association. And I think if anybody's been involved with the APTA, you understand that they do advocacy work, but that's not their primary objective. Their funds go to support many different aspects of the association, and about 7% of the dues that you pay go toward advocacy efforts. Our goal is to establish an association where 80% of the dues you pay goes toward advocacy. And we're small, but we did start with our advocacy tablets initially to get a grassroots effort going, to get letters sent to Congress for HR 10073 to increase the Medicare fee schedule. We did send out about 650 emails. That's pretty good for an association of less than 200 people. I think that's a good start. And the more therapists we get to join, the more I think we can make a difference. And really, our best advocates are our patients. The goal is to get more therapists to join and then leverage our patients to reach out to legislators and to ask for change. Because otherwise, we will never have enough money to make a difference. We will only have enough voices to make a difference.
Yeah. Scott, I completely agree with what you said there about patients. We have had either where we treated legislators, Pennsylvania's Harrisburg, so we have legislators that'll come through, senators every once in a while, and we've had some meaningful change by treating them, and then something related to a PT bill come through. The other thing that has happened is we've treated larger people that own large companies. One off the top of my head, she had over 300 employees, and she was able to make change in a day because she was, paying for so many people. Love what you said there. Can you talk more about the advocacy tablet, what you're doing, and then how that's being used to complement what you're doing, farther the cause with the UPTA?
The advocacy tablet is basically just a Kindle, a small Kindle that, if you remember, we did basically a trial of it with 10 clinics, and I sent them out to the 10 clinics, and basically the homepage is set to the UPTA advocacy site where the actual legislation is listed. You click on it, you give it to your patient, fill it out, or you fill it out right in front of them for it. Takes about 30 seconds. I generated at least 5 to 6 letters that populate. It's always changing. And the nice thing about what we have in our advocacy site, we can generate letters to anybody at the state level as well. Say in Pennsylvania, fair copay legislation's up, and that's something you want to advocate for in Pennsylvania. I can create the template for you for that bill that you can use in your state to advocate with your patients. And it's honestly, Chad, it takes 30 seconds for them to put their name, their address, their phone number, the email, and it's done. And if we can generate lots of letters, it's going to make a difference. And then also, if we can generate some phone calls on top of that, they'll eventually have to pay attention to what their constituents are looking for.
Perfect. Thanks for doing a deeper dive there.
If we go to this page, you'll see that the continuing resolution that happened last year didn't get pushed through, and a much smaller funding of the government bill was pushed through. And what happened was, on X, or the old Twitter, the components of the bill got out, and the people that live in the United States didn't like it. They started calling their representatives and their senators saying, we don't want this big inflated bill. We just want something that speaks to, continuing the government with not all this other stuff attached. Now, one caveat was the Medicare physician fee schedule fix was a part of that, and that got scrapped at the last minute. But you can see what happens when people actually reach out to their legislators and say, I don't like this. They have to listen to you. Legislators want to continue to stay in office, and that's their goal. They have to listen to their constituents. The problem with physical therapy is we're very passive. We don't really do much. We're a profession that doesn't speak up. That needs to change because everybody else is speaking up for themselves and we're being left behind. The goal of the UPTA is to become that grassroots advocacy and to really push the narrative of what we want to be changed. And this just goes to show you things can happen if people speak up. There's a lot of frustration with the APTA because of the lack of advocacy wins. That's pretty much why we're doing this. Let's consider ourselves an adjunct association to what they're doing to help push our narrative even farther.
And just to shed some depth on that bill that was nixed because of Twitter or X, it was 1,500 pages. and I think the review time was 3 or 4 days.
There
And
wasn't enough minutes in the time period to get it looked at to read every page.
that there were some pretty smart people that started dissecting that and just found a ton of waste. And I think what was exposed, especially in this case, was how much it was, how many times a legislator was like, okay, I'll approve this as long as you approve this for my constituents. And it ended up being quite the snowball
Massive,
effect. It was,
massive amount of waste.
yeah.
This quote I found when the past president of APTA, there's a big article, I think it was in the AP News posted, it was nationwide, went out there. And for when she said, I just don't think that people are aware that that we're the best kept secret in PT and that the public doesn't know they can go to a PT without a physician's referral. For the last umpteen years, the APTA has worked on direct access, but here's the past president saying the public doesn't know that they can do that. That's a disconnect right there. Money should be spent to educate the consumer that we have direct access, but they don't do that. There is not a lot of money spent at the APTA on public education. You can look at their 990 and see where the money goes. There's not a lot of it that goes toward advertising. Direct access, it's not gonna solve all the problems. It's gonna make it easier to have our services to the public, but also it's not fixing the payment model. Do you really want to have more patients that come in your door for $50 a visit? I mean, I don't think that's what we're looking for. Direct access is a positive, but it's not going to fix everything. It's not even direct access, even with the Medicare plan of care, is not even true direct access. Now, as long as you have a prescription or an order from a physician, you don't have to send it off to get it signed. It's not really direct access at the Medicare level, and that's what we really need is to be able to have direct access at the Medicare level and to opt out of Medicare. Those are things we need to focus on.
I always thought of direct access as a shell game a little bit, where we feel like we're getting a benefit.
Right.
It,
It's
back in
not true.
2003, 2004, when we had it here in Pennsylvania, the expectation is that it would solve our problems, and that was not the case at all. Love that.
This is interesting. So if you remember last year, the APTA touted the value of physical therapy report, demonstrating how much physical therapy saves money for insurers. However, the last year I spent a lot of time looking at healthcare policy. And when you look at the Affordable Care Act, what was written in there sounds good on paper. It's called the medical loss ratio. It requires that insurers spend up to 85% of all the premiums collected on healthcare for their members. Sounds great, right? But then you start thinking, well, how does an insurance company make money? Well, they can only make money on the leftover 15%. That means they have to drive more revenue. In order for them to drive more revenue, that means they have to charge us more for our care. And how do they do that? Well, health systems pay at a 3 to 10 times rate for most services. Higher spending is a higher profit for the insurance company. Do they really want to save money by sending people to physical therapy? I don't know. But if you look at this right there, 15% of $10 billion in spending is 1.5 billion in profits. If you look at United Healthcare at the third quarter of 2024, they had $100 billion in revenue and made $6 billion in profit. Granted, it's a 6% profit level, but it's still $6 billion. That's the reason why all of our policies are getting more expensive. And think about it, as an outpatient provider, you haven't gotten a raise from an insurance company in forever unless you try to get one. Yet your premiums go up 15 to 20% every year. Where's that money going? It's not coming to the providers that are independent. I think you just got to take a closer look at this. I mean, it's true, we do save them money, but do the commercial insurers really care about that?
Scott, I completely agree with you on this one. I saw this post, it resonated. I know I've written about this, I've talked about it in quite a few webinars and presentations over the years, but that the CEO of whatever insurance company you want to talk about, they have a fiduciary responsibility to the shareholders to improve and increase the value of that company, the value of the equity. And the only way that they can get that stock price to increase is to increase earnings, which goes exactly to what you're saying here. And we need to realize that as a private practice therapist, that we are a threat to that, right? If somebody goes and cancels their $118,000 spinal fusion because they had $1,000 plan of care with us, that is a threat. And I think we need to understand the game, especially if we're going to win at it long term. And there's a lot of other pieces written on this, but it's definitely the minority voice right now, and we need to make it a louder voice.
Correct.
Love that.
And then we can't beat the health systems at their game. They're large hospital systems or health systems. They negotiate from a position of strength. They have better bargaining power, and since they control such a large portion of the insurer's patients, they can negotiate better. For example, in our area, Johns Hopkins about 2 years ago, which covers many patients, decided that they were going to drop Blue Cross and Blue Shield because they weren't paying them. Blue Cross Blue Shield was like, oh no. And then all the patients start calling Blue Cross Blue Shield saying you can't drop lose Hopkins. Blue Cross had to go back to the negotiating table and basically renegotiate the rates, and Hopkins was happy with it. Next thing you know, Maryland's rates go up 15%. They're paying top dollar for care at these facilities. And that's one thing is as independent clinicians we need to understand is when we can get a hold of the reimbursement rates for some of these systems, which is in the machine readable files, we can crack that code. Then we can say that, hey, if you go to the XYZ hospital and get your care there as an outpatient, for therapy, outpatient wise, it's going to cost you $270 a visit. But you come to us, it's going to cost you $92 a visit, and you're paying a deductible. If you make a decision, you should be coming to us. And it should also give us leverage to negotiate a little bit better with our contracts and say this is an unfair playing field. And I think we need to look at that too, is like it's just an unfair playing field, and we need to start fighting for ourselves. Like we can't beat them at their game, but we just need to find ways to join together to make a difference.
I it I have a question about the machine readable files, and I hope I don't go down too much of a rabbit hole here. At Breakthrough, we have people who are very tech savvy. The recommendation was to hire somebody from Upwork to do that. Can if I like, let's say, who's the first example I saw, Anthem. I download the machine readable files. It's 13 gigs, which is tremendously
Sure.
prohibitive for me to process myself. But let's say I find somebody from Upwork, a person that could do this. I hire them, and I have that information that is specific to me as a physical therapist with all the codes that, your owners graciously inputted, the 20 or 30 top codes that we use in PT. Am I allowed to share that with other owners through the UPTA?
Of course, it's those are public files. They're out there for everybody to use. It's the Transparency Act. It allows it. Remember, there used to be a time where you could not tell me, Chad, what you got reimbursed. Remember that
Absolutely.
was
Yep.
now those
Haven't seen that
files
long
are there and they're public, and it's the Transparency Act of 2020 or something. It's out there. I'll find the actual law that says these are there for us to see now, and
Yep.
we can share these. There's no reason we can't share these now. And we need to know. We need to know what they're getting at the local hospital system for the same services.
Yeah. And I will say, whatever the largest MacBook Air is that you can buy, that's what I have. And I tried to download that file and it shut down my entire
Did it
computer
really?
because of that. It
Size
scared for a bit, but I figured it out, and we will get somebody, I
crack the code.
crack the code, start publishing those. And I think it's something that we all should have. And, you mentioned the $92. I know I had a patient in my immediate family who went to the hospital system for various reasons, and they received 4-unit visit of physical therapy at our local hospital system here. And the charge was $1,200 for 4 units,
Oh, whoa,
and the reimbursement was 312.
that's insane.
And then I went to Tracy, our CFO, and I said, "Hey, Tracy, what would we get from this insurance company for the same exact 4 units?" And it was $92. I can't
I
believe
was
it.
right.
312 and 92. And I was like, wow, how would that change the game if we even had half of that? If I was getting $200 a visit, that would allow us to, better team building, better staff retention. I could buy more market share. I could, yes, I could easily see one patient an hour or one patient every 90 minutes.
100%. Our
That,
quality of care would go up. The burnout ratio would go down.
yeah.
Everything would be better.
And I could have marble floors in my foyer and everything else that the hospital system has. It's
Right.
pretty wild. Uh, Thanks for going through those, Scott. And I want to talk about, the real problem that we're facing, the real crunch that we're under, and over here on the right, what I did is I went back through ultimately 1994 with a physician fee schedule that determines how much we're reimbursed by CMS. And this is the physician fee schedule. And that blue line is where we are at, including in 2025. And if you look at the number in 2025, it is less than where we were in 1994. Now, what's the adjustment for inflation for the physician fee schedule? By law, there is none. And if you think about that, the value of the dollar today is worth less than 48% of what it was back in 1994. You know, if you needed a dollar to buy something in 94, today you need $2. If you look at, you know, what Scott, you and I made when we first came out of PT school, the salaries have basically doubled during that time, if not slightly more. Our cost to provide care has gone up. That is represented by the green line. Our reimbursement, our income has gone down. That's the blue line. Our cost to provide that care has gone up. That's the green line, and that's the CPI, inflation index, which is also up 42.5% since 2019 in the last 5 years. That's pretty brutal. And when you're looking at that, what is the difference between the blue line and the green line? You can write that in the chat. What's the difference between the blue line, income, green line, expenses? What's that called? Scott says profit in all caps. Yep. Profit. Anybody call it margin of safety, margin? Yep, right. And this is not going in the right direction, right? Very easy to see how we're coming to quite a crossroads here, literally speaking. You know, and it's becoming harder and harder to rely solely on insurance-based revenue. We have increased employment expenses, increased space cost, increased equipment cost. It's more expensive to market our services, more expensive to remain compliant and keep up with EMR and, you know, the hardware costs that we have. In the end, we have shrinking profitability. And just to give you an idea, back in 2018, Bob Kowalik had shared that the average private practice margin was 14.6%. In 2023, that fell below 10%. And it does not seem to be going in the right direction in the last year or two. Anytime that we're under 10, Greg Crabtree, a CPA who specializes in service-based businesses, he has shared that that is, you know, he calls it the new break even, that if you're not more than 10% profitable, you're a speed bump away from having to close your doors and could no longer provide service. The other thing is, you know, you have gone through school, you did 4 years, 5 years, maybe 7 years to earn your DPT, to earn your PT degree, your MSPT, whatever it is that you have. And at the same time, if you have a MSPT like myself, or maybe even a bachelor's in physical therapy, you likely have 25, 30 plus years of experience as well. Are you worth $80 an hour, which is the reimbursement rate that we had back in 2003? Are you worth $160 an hour? Right? Most of us know we have the expertise, we have the knowledge, we have the outcomes to justify that higher rate. And there are some things that we can do about that. At Breakthrough, our specialty is helping practice owners grow despite what is happening with declining reimbursements and increased cost to provide care. And what I want to get into next is really 3 marketing strategies to improve your payer mix. These are things that you can do today to move the needle in the right direction and help mitigate the losses that you're having with the Medicare cuts and increased cost to provide care. We're going to talk through reactivations, and I'll give you a little catch there of how you can think about that differently. Reactivation is, Scott and I were talking about this before the webinar started, but you know, I saw somebody 2 years ago for knee replacement. Now they're coming back for back pain or a shoulder issue or whatever that might be. That would be a reactivation. A patient that you saw in the past coming back for additional care. Number 2 is employers who offer your best insurance. I'll give you a shortcut way of how you can figure that out. And number 3 is differential diagnosis. It's thinking through what diagnoses do you want to attract into your clinic, and thinking through what's the lifetime patient value? Can I see this patient profitably, or am I going to lose money on this diagnosis? And just a quick caveat with that, 21 years ago, 22 years ago, when I started in private practice, I vowed that I would never do that. We're forced to do it today. We have to be more disciplined. I would love to build a practice on, for example, you know, BPPV. We love it. We treat a ton of it, and all of our therapists are trained in how to treat it. Fantastic love, but you know, we see that person for 1 or 2 visits and they're gone. And we can't possibly go into the marketplace and differentiate our practice because of BPPV. The first one here, reactivations with a catch. You have a patient list, likely in your EMR or your marketing software. You can go through the insurance, right? So you know that if UHC is your lowest payer, that you don't have to, right? You could eliminate UHC patients from your reactivation efforts. You could do that. Here's another way to think about it. Who's your best payer? Write your best payer down. Who's your best paying insurance? Write that down. In my case, it's Highmark Blue Shield, right? I can go through my patient list and see who has Highmark Blue Shield, and I can pick a single patient. Let's say it's Mary Smith. Mary Smith has Highmark Blue Shield. FRM is this. It stands for frequency, recency, money. The wheelhouse to think about that if you're insurance based is you can think about, okay, who is somebody that I haven't seen in the last 6 months, but I've seen them within the last 2 years, somewhere within that 18-month time window. That's frequency and recency there. And then was this somebody that I want to work with again in the future? That's the money component. We know Mary Smith in this case has Highmark Blue Shield. I then can send her a simple message. We've tested thousands of messages. Here is the one that works best. Hi, Mary. This is Chad at Madden Physical Therapy. It's been 6 months since I last saw you for your shoulder. How are you? That is it. That simple message, whether it's sent via text, which is our favorite, best response rate is about 90%. You can send it by email, you can send it by direct message, you can send it by snail mail. That very simple message has a 90% plus response rate, and we know about 70% of the time when that person gets back to us and says, okay, this is what's going on, or I'm doing great and my knee doesn't bother me anymore, or shoulder, whatever the malady was, then we can say, okay, great to hear from you. Is there anything else going on? Right? We know that about 70% of the time that person's going to be reactivated. And now we've just hedged our bet around our best payer, our best insurance. The example I gave is one-to-one. We can also do that with one-to-many. One-to-one is one clinician to one patient, where you're going through, one at a time through your patient list. And we notice that if our clinicians just do 8 of those a week, their schedule's full, right? They're going to see 50, 60 visits plus a week, and their services are going to be in demand with the higher payer. That's number one, reactivations with a catch. Number two is employers with benefits. I was just on with a large practice. They have 70 plus locations, and we were talking about, how to market to the employers in their area that have the largest or that have the best payer, right? And I'll give an example. In my area, we have a credit union that offers our best paying insurance, and we've had a relationship with them for 20 plus years. And they have about 500 employees on site. And how would I get that information? How would I know? Right. And this is what I walked through with that practice with 70 plus. I said, well, do you have an EMR? I asked if they had marketing software and they said no. I said, okay, do you have an EMR? And they said yes. And I said, well, just go through who's your best payer. They said their best payer, and I'll use Highmark again, Blue Shield. And I said, okay, so I go through the list until I see Highmark Blue Shield. And then I go to the next column, which says what? Employer name. Right? We have an immediate connection. I don't have to go out. I don't have to buy a list in the marketplace. I don't have to, anything like that. This is not tricky at all. I'm just walking through my patient list in my EMR, who has my best paying insurance, and then who are they employed by. Most of you are going to have that information as well. Then what we need to do is swim upstream. We ask for an introduction, but ultimately you want to talk with the HR director and figure out, are they doing health fairs? Are they doing, in the case of the credit union, they do a health fair, and they also do monthly lunch and learns. Are they doing, any sort of screening or anything like that? Is there some way that I can provide value to that employer that we're attracting more of the better paying patient? And I just want to plug in to their pre-existing systems. That's number two, is employer with benefits. You already have this information. You can, very quickly, probably today, know exactly who your top 10, top 20 largest employers in your area are that are offering the best paying insurance, your best paying insurance to their employees. Number three is a differential diagnosis. And we're on Raintree. I know Prompt does this. I know quite a few others do as well, but you should be able to run a report based on diagnostic code that gives you the value of the diagnosis. I'll use a quick and easy one. Years ago, we had a therapist who retired, but she did pelvic floor incontinence with biofeedback. And she also did post-mastectomy lymphedema. And then she also specialized in scleroderma treatments. And amazing therapist, fantastic outcomes. And then what we were doing is, as she had announced her retirement, we were looking for somebody to do pelvic floor biofeedback and to learn from, her name was Marianne, as Marianne was retiring. And we could not, at the time, we could not find the right therapist who would treat in the same way that Marianne did for pelvic floor. We ended up closing down the program. As we were thinking through this, and I was trying to figure out how much money should I be throwing into investing in finding a good pelvic floor therapist that wanted to treat this way, we took a look at the value of the diagnosis. And we noticed that for post-mastectomy lymphedema, the value was great. For pelvic floor with biofeedback, on average, it was 4 or 5 visits. The value wasn't really there. And we were actually losing money on those patients. I never knew that until Marianne was retiring and we ran this diagnosis report. It's the same thing that, if you were on here in the beginning, you heard Scott and a few of you as well talking about the value of a vestibular patient, how it's significantly higher. There tends to be more comorbidities than some of the other diagnoses. You should know what your top 2 or 3 are, right? And it's the same idea here. You go through, you think about your perfect patient, somebody that you want to see, and then you think, okay, how can I attract more of this person? I'll give you another example. I just shared that pelvic floor biofeedback years ago, 4 to 5 visits on average. That was a patient that I would never market out in the community with. Last year, we wanted to test it. We have 2 therapists now that specialize in pelvic floor. And we noticed something very unique around for pelvic floor incontinence, there are 3 main groups. There is pregnancy, expecting mothers who are incontinent or recently had a delivery, right? Recently had a child, new mothers. That's group number 1. Group number 2 is men with prostate issues, tends to skew older, right? Very difficult for us to find, make aware, and that they're coming in, right? And then the third one is people undergoing gender reassignment, transition. And when I initially looked at, we wanted to test run a pelvic floor workshop to see what happened. And we were thinking through this from a marketing standpoint, and we said, okay, of these 3 groups, when each one of these people come through, group 1, expecting or new mother, group 2, men with prostate issues, group 3, people undergoing gender reassignment, which one of these can we attract in a way that makes sense for our clinic? And the obvious answer was number 1. Now, before that, when I had looked at the copy for our advertisement, for our landing page, for our emails that were going to people that registered for the pelvic floor workshop, we were trying to be everything to everybody. You can't possibly do that, right? Anytime we try to be everything to everybody, we're nothing to nobody, is the popular cliche saying. But we said, okay, the first place we're going to go to is expecting and new mothers. Now, if anybody else comes in, we don't discriminate in any way. We invite everybody, but we very much focus our messaging around new and expecting mothers. We ran this pelvic floor workshop. Is amazingly successful because not only do we see the expecting mother before she delivers, we then do a follow-up 6 weeks after delivery and do a checkup then. Many of those reactivate as well. But you want to think through, in Scott, your case, it's vestibulars. How can you attract that patient? Where are they at? What media are they consuming? How are they talking about their vestibular issues? What terminology do they use? We want to make sure we align that market. In this case, we know that it's vestibular, and we know that the demographics with that, our market, our message. Are we talking about vestibular problems, balance and dizziness issues, using the same words that they use and the same messaging, how they think about it in their head? And then are we using media that they're consuming as well? That's the process that we go through for, attracting more, especially when we're going to the cold traffic via social, via legacy media, all that offline media with print, direct mail, TV, radio, advertising on Meta, advertising on Google, et cetera, we can decide who that ideal patient is and then think through and solve for how can we attract more of them. Having said that, and we just went through the 3 marketing strategies to improve the payer mix, it's really part of a larger system. And when we think about how we treat a patient, there's probably like 5 or 6 steps that you have in. Most of us can do this with our eyes closed. We know if somebody walks in with a vestibular issue, we know what we're going to look at. We know the test that we're going to do, whether it's timed up and go or gait speed, or maybe we have, a balance metric score that we're going after. But that's the first thing we do is we look. The next thing we do is we create a treatment plan. If there's lower extremity weakness, that's likely going to be part of the treatment plan. If there's I mentioned a BPPV issue, we're going to address that. If there's a VOR deficit, we're going to address that. That's the treatment plan. We have treatment strategies that are incorporated into that plan. We implement it. We go through the treatment for the 12, 18, 24 visits, whatever that might be. And then we measure progress along the way. In the beginning, we were able to walk 10 meters in 27 seconds. And today that's 15 seconds. We've made tremendous progress there. That's our measurement. We reassess, and then we go through the process all over again. That's a treatment system. And thinking about profitability, we have the same 6 steps. We audit. We teach something called the Profit League audit, which I've been teaching now for 2 years. It's a way to look at your revenue above and beyond what's happening with your dashboard metrics. Yes, you can know that your average revenue per visit is $87.44. But looking at on a granular level, what's happening with each patient, which is what we teach in the Profit League audit, is valuable for practice owners who want to change what is happening with the revenue. 2 quick examples there. A year ago in Orlando, Lance Gross shared that he went through the Profit League audit and it was worth over $1 million to his practice. Now, Lance has 17 locations, and your situation might be different. Maybe you have a larger practice or smaller practice, but it was very valuable to Lance. Dave Bender, who's in Maryland, heard Lance talk about that story. And Dave went back to his clinic and it was worth $250,000 to his practice by just going through that Profit League audit, one simple exercise. The next thing that we do is we create a plan. We teach something called the Profit Planner, which is an extended pro forma that you build out for the next 12 months, the next 5 years. And what that does is it helps you pick strategies that are going to move the needle in the right direction for your practice's profitability. There are 12 different strategies that we've isolated, we've identified that private practice owners are doing today that are moving the needle in the right direction. I just shared 3 of the marketing ones with you, or at least a simplified variation of that. But there are 12 things that you can do. Every practice is different. What Scott is going to do, for his clinic in Ocean City, Maryland, is different than what each of our clinics are going to do here in central Pennsylvania. We then implement them. Over the course of the next 90 days, we measure the results. Did we move the needle in the right direction? And then we update and repeat this every 90 days. And this is a system that once you have it in place, you're doing this for the rest of your private practice journey, as long as you're trying to move the needle on profitability. We teach this, we deliver this by way of a course, a program that we have. And the program is called Profitability Under Pressure. It's helping owners increase their per patient revenue, sometimes very dramatic. I think $15 within 90 days is the biggest win that we've had there far. Boosting utilization of cash-based services, which many of us are adding. We're doing those add-on services as well. Reactivate past patients and doing it in a smart way with both automated email and text campaigns. Reaching the ideal number of patient visits each month with confidence. Biggest strain on our profitability in private practice right now is underutilized schedules and underutilized space. Underutilized space is where we have a 3,000 square foot clinic and we have 1 clinician. It's for practice owners who want to increase profitability and revenue per visit. We're looking to sell cash services or looking to add on cash services. You have a growth mindset and you're engaged. There's a poll coming up on your screen right now. If you're interested in learning more about how you can increase profitability here in 2025, click yes, and a member of my team will reach out to you and follow up and show you exactly, give you more details of exactly what profitability under pressure is. The other thing that I wanted to say was this: I said I'd have a special announcement. We just decided that this profitability under pressure, this is the last time that we're going to do it. This is the sixth class group of practice owners. We have a great group of practice owners that are in right now. We're about to get started with the program. It's going to include 13 implementation calls, but this will be the last time that we do this profitability under pressure. And to apply, you can go to getbreakthrough.com/apply. There is a short form. I'll show you exactly what that looks like. And then we can open this up for Q&A. That form is going to look like this. It'll take you to a page that looks like this. You'll just click apply now, and you can read other details on the page. It'll take you about 2 minutes to complete, and then you're going to click apply now. Once you do, you'll be taken to a page to schedule a time with a member of my team. We want to make sure you're a private practice owner, that you're not a POPs or HOPs practice. That's very much in alignment with, what we're about, with our vision, who we work with. And we want to make sure that the program's right for you. And plus, you'll get a lot of other details, all the details for the program. I know one of the things that happens a lot is what all is in the course. We not only have the 13 implementation calls, but over time, with various owners going through the program, they've added to this as well. We not only have all the coursework, and this can be a little overwhelming, but we go through it in a very structured, organized way within the curriculum. There's a ton of other stuff here for you to access, many of it by other owners or contributors. We have 8 other experts, contributors in the course, including Mary DeLong, Paul Welk, Bob Kowalik, Mark Callanan. But you can go through conversion, dropping a lowest payer, how to do that, facility checklist if you're selling your practice one day, or what should your clinicians do when there's a gap in their schedule. We go through all these tools for finance, helping you set practice goals, how to hire, including a training that I did live with an owner on how to write an ad in 20 minutes using AI and developing a scorecard. That's huge right now in the marketplace because most of us are hiring. Marketing, ton of marketing content in here, and renegotiating rates, software. It's quite a bit of content. All of this is in the program, and we house it all within a single site. Plus, again, you get those 1-hour implementation calls each week to help you implement this into your private practice. One other bonus that I wanted to share with you, getbreakthrough.com/apply. And the other thing, if you are not a UPTA member yet, when you enroll in profitability under pressure, we'll make donation to the UPTA for your membership. We'll buy your membership. The other thing that we'll do is if you're already a member, we'll make an additional $150 donation to the UPTA. I think I was one of the first couple hundred people into UPTA Facebook group early on with Scott. I've been following everything you were doing. And to be fair, I was very skeptical in the beginning. Love everything that you're talking about and the mission. The more you talk, the more bought in I am. And we want to do everything that we can here at Breakthrough within the Breakthrough community to support what you're doing with the UPTA.
Thank you, Chad. I really appreciate it. Truly.
Great. At this time, we'll open it up for questions. What questions do you have around marketing, around influencing your payer mix with marketing? A lot of other things we can go into there, but what questions do you have? Type it in the chat, or I think you can raise your hand. If you raise your hand, we can bring you on live. Questions for Scott on the UPTA or myself? Guess it's me. Awesome. Jim, great question. What is a typical timeline for getting through implementing PUP? Let's start with this. If we're going through the circle here, and I can just back up and show you. The audit in Lance's case with 17 clinics, that took him, I think he said 90 minutes. Dave said the same thing for his practice. The audit is going to take you 60 to 90 minutes to go through. probably learn that within 5 minutes to an hour. That's step one. Once you know how to do it, you're only going to get more and more efficient, right? If you think about like the first time you ever evaluated a back pain patient, probably took you an hour and a half as a student. Now you could do it with your eyes closed in 15 minutes, right? You know exactly what you're looking for. That gets faster. But first time doing it, give yourself 90 minutes to implement. To create the plan, we do this every year. Every single one of our clinical directors does it for each of our clinics. And it's the very first thing that we teach in our clinical director training. That plan, same idea, takes 60 to 120 minutes to put in place to implement. Now, and when I'm talking about 60 to 120 minutes, that's uninterrupted time. That's not like trying to fit that in. That's focused time where you're dedicated. You've blocked out time to work on your business. The strategies, depends which strategy we're talking about. You know, if you're going to take one of the strategies could be taking your entire practice and going from 60 minutes over to 40 minutes. That might take some time, especially if you have, 50 or 100 clinicians to get on board. I'm not sure how to gauge that one. The profit levers in general, there are 12 of those. We recommend that you pick one or two per quarter, right? For example, that reactivation one that I shared with you today, you could put that in today, right? How long does it take you to message 5 or 10 people? Maybe 10 minutes, 20 minutes, right? Not long at all to do. And then sharing that with your other clinicians. The profit levers are kind of practice dependent in the implementation there. The total investment of time to learn the system, I would say 13 hours took, over the course of a quarter. Total time to implement that, same idea, 6 to 10 hours of implementation. And as long as you're focused on that, measuring, I'm guessing that you already have measuring, metrics in place where you can see, okay, here's the strategy that we have in place. Did that improve our profitability? Right? You're going to be able to gauge that pretty quick. Did this improve our number of new patients coming through with this payer? Did this change our payer mix? Did this add to our revenue? Did this decrease our costs? Like you're going to be able to see that pretty quick. Great question. Why is this the last class? We've never taught much information, and really the wheelhouse for breakthrough is marketing. What has happened over time is there's a little bit of, we'll call it benefit creep. What happened in the very beginning, we were teaching nothing but marketing. And then over time, what happens when somebody solves their marketing problem is now they have a finance issue. And, I've been teaching this for a year and a half. This coming out of the pandemic, this seemed to be the biggest problem in the marketplace. Then, last year, the thing that we heard the most about was I need help hiring. That is just information. That's not something, and basically we're getting farther and farther away from what we really are, which is, helping practices market. I believe that all roads lead to marketing, but I'm also very biased as a private practice owner and marketer. Life decision there, Olga. But it's real. It's a final decision. We talked about it as a company, and we're not going to offer the program again in the future. Great questions. What else? All right. If there's not anything else, Scott, thank you again for doing this. You're great. Love what you're doing as a private practice owner. You're really taking on quite a bit. And I have 2 good books I'm going to send you that very much support what you shared in the pitfalls that we're going through, what's going on with the healthcare system, but it shed a little bit of behind the scenes, what's going on with that, the medical industrial complex. And I think you'll find it fascinating.
Thank you. I appreciate it.
Thanks, Scott. Thanks, everybody.